Welcome to Connect with the CEO, and I want to thank you for joining us. This session today is being hosted on Facebook, and all of you who have participated in the past know the drill. We want you to put any questions you have in the news feed on our Facebook page, and my trusty team here will make sure that we integrate that into our conversation today with one of our newest DHMC providers, and her name is Dr. Cynthia Taub. And this is only her third week here, so we've given her a real New Hampshire welcome. Cynthia, I think we probably had at least a foot and a half of snow since you came here. But she's also the section chief of Cardiovascular Medicine here at our Heart and Vascular Center. Welcome, Cynthia. Thank you for joining us.
Oh, I'm honored and energized to be here. Thank you, Dr. Conroy.
So you can call me Joanne. Everybody here does. So anyway, we're thrilled you're here. Now, for our community to get to know you a little bit, talk a little bit about your background, where you did your medical training, and where were you working prior to coming here to Dartmouth-Hitchcock Medical Center?
Well, to give you a short version of the answer, I worked at Montefiore Medical Center, Albert Einstein College of Medicine, as the section head of non-invasive cardiology and cardiac imaging for 13 years. But I think it's only fair for me to go way back and tell you a little more about my journey back to the Upper Valley. So I was born and raised in Beijing, China. Both my parents are physicists. I received my medical degree at Beijing Medical University. Upon graduation from medical school, I was very fortunate to have received a Dartmouth scholarship to study molecular and cellular biology. So in 1993, I arrived on campus. Hanover became my second hometown. In graduate school, I studied under the most gracious mentor, Professor Rob McClone. He's a trailblazer in the field of circadian clock, and he has dedicated his entire life to the academic research and education at Dartmouth. Continues to be an inspiration. Just a few days ago, we were talking about how circadian clock might have played a role in the early morning heart attacks. As you know, in the early morning, the hours that there are higher incidence of acute heart attack. I'd love to continue to work with him in the near future. So after graduate school, I went back to clinical training in cardiology, advanced imaging, and landed in the Bronx. As you know, the Bronx is one of the most indigenous and racially diverse borough in New York City. Montefiore is nation's leader in population health innovation. Learned a lot and developed my academic career there. And have become a more mature leader in cardiovascular medicine. When this position at Dartmouth-Hitchcock became available, it just felt completely right for me to come home.
So as somebody that started their training as an undergraduate at Dartmouth in the Upper Valley and ended up returning, I understand it feels like life has kind of gone in a full circle. But we are thrilled to have you here. Now, I'm very familiar with the Bronx, and in fact, the CEO of Montefiore was a friend of mine. And there are some things that are a little bit different up here. I'm not sure we have any Grubhub that would be able to deliver food to your house, but there are so many advantages to living in the Upper Valley, and you will be able to appreciate those as you spend more time up here. And we're thrilled that you're here. Now, your special interest is echocardiography. Not all of our viewers really understand what that means. Can you talk a little bit about the specialty and maybe the evolution of the specialty? Because the technology is pretty amazing now with echocardiography. changed a lot since it was first introduced into clinical practice years ago.
Absolutely. Echocardiography, in short, echo, you hear it all over the news community. We, as cardiologists, we know that it's one of the most readily available cardiac imaging tools. Using an ultrasound technique, we're able to look at heart muscles, valves, blood flows, just like looking at a baby in a pregnant woman. It's painless, there's no radiation, and there's no risk to the body. And yet it tells us so much information about your heart health. And imaging is really an exciting field because you see it, and it's not stagnant. It's constantly evolving. My children ask me, Mom, what do you do at work today? I tell them, I spend the whole day watching movies. What do? I look at the heart three-dimensionally. I can see the surgeon's view without using a knife. How exciting is that? So nowadays, there are more sophisticated techniques to look at, heart valves, to look at myocardial heart contraction mechanics, and also, artificial intelligence, machine learning, virtual reality, and cloud-based computation has entered in the field of cardiac imaging. The sky is the limit. I'm really excited that I'm in the field of imaging.
So when would somebody have a cardiac echo? What would be the normal reason why somebody would have that? That's the first question. And then I think a follow-up question is, there are some tests that are more reliable in men versus women and women versus men. And is there any type of gender distinction around cardiac echo?
So the number one driver for getting a cardiac test, such as an echo, is how you feel, your symptoms. Is there a change in your symptoms? For example, are you experiencing new chest pain, difficulty breathing? If you climb up 4 flights of stairs every day and all of a sudden you couldn't do it, there's a reason for us to see, okay, is this cardiac? Is there any change in your cardiac function, or any leaky valves, or the valve is narrowed? So symptoms is number one. And other indications include if there is any new murmur, any new EKG changes, or are you going to participate in a competitive sports for, NFL, or even college competitive sports? Those screening tests with an EKG, if there's abnormality, an echo would be the next step. I can list, maybe 20 reasons for getting an echocardiogram. But I think the number one thing is, if you have symptoms, go see a doctor, and the doctor will, based on your comprehensive assessment, make a decision whether echocardiography is indicated or not. For men and women,
men and women.
Yeah, men and women in general. As for the indications for a cardiac echo exam, I don't see significant differences in terms of indication.
Yeah. Have you ever done an echo? I'm sure you have in your past. When you started to do the echo, you saw something you didn't expect in the heart.
Oh, absolutely. Every day. Every day. That's what's driving me to practice medicine and to be in cardiology. Every day is a new day. Every day I learn something, and I'm able to pay back and teach my students and inspire them to be passionate about cardiology and cardiac imaging.
Now, we were talking about, before we got on the air, about really interesting applications of cardiac echo. Many people that are undergoing treatment for cancer, if they have to have chemo that has a cardiac impact, will have a cardiac echo as a screening. I know you want to kind of expand kind of the application of cardiac echo. It's a very it's a really, it's not easy test, but from a patient's perspective, they don't get stuck with a needle. It is actually not unpleasant to have a cardiac echo. What are your plans for the section in terms of expanding services and or developing some of the academic pursuits in the department?
So I've been here for 2 weeks. I'm still trying to find my ways and, calling people their right names when everyone is wearing a mask. So I'm coming in with humility. There's so much to learn before I can say what program can I build, what program can I expand. What I know is, at Dartmouth-Hitchcock, in the past 2 weeks, I've learned that the mentality here is people first. I'll give you an example. Every new employee will have 2 hours PPE training. I've never seen it anywhere else. And the purpose is to protect our providers, but more importantly, I think, is to make sure when your providers are seeing one patient, another patient after another, there is no cross-contamination. So, really the program here to ensure safety impressed me tremendously. And coming back to my goals, there are short-term goals, long-term goals, but the ultimate goal is to help our patients. I've thought a lot about what I would like to build here at Dartmouth-Hitchcock. And, I can talk about this for an hour, but I won't torture you. With that, I will summarize my thought process with, I would say, 4 Ps, okay? 4 Ps. Number 1 is people. We have great people here, world-class faculty members and dedicated APPs and highly skilled sonographers and technologists. So, I would like to be someone who's able to create an ecosystem to make our people flourish. Toni Morrison said that if you have some power, use that power to empower others. So that's number 1 P, people. Number 2, Joanne, is the program we were talking about. In the past 30, 40, 50 years, DH has very mature and top-notch programs within cardiovascular medicine. And I would like to consider expanding and strengthening our women's heart program, how to better take care of women with heart disease going through pregnancy. Okay, our scoreboard for the US is horrible. We rank the last in terms of maternal mortality in developed countries. So how can we strengthen that and protect our patients? And the next program, I think, is much needed for expansion. We call it cardio-oncology program. Dr. Alan Kono has been, dedicated to this program, and he's retiring. I think there's so much for us to do because of the value of imaging in stratifying patients who are at higher risk for developing heart problems when they undergoing chemotherapy, radiation therapy. As you know, a lot of these chemo drugs have potential toxic effect to heart muscles. So using echo, you're able to dissect exactly how the heart muscle fibers are contracting before the patients even get chemotherapy. You're able to say, okay, this group of patients have higher risk for developing cardiac toxicity. They need medications to protect the heart, or they need a different regimen of chemotherapy infused slowly in separate doses so that they will go through chemotherapy safely. So this is the program I was talking about. Allow me to talk about the 2 other Ps. Number 3, the P is process. I think, with efficiency in mind, we need to look at our process. And in the post-COVID era, we'll we're going to be looking at how to incorporate telemedicine into our routine practice. How do we create an environment to ensure equity? So the fourth P, I would say, is profile, where you would say prestige. We have great people. How can we elevate and promote our people and program to the national and international level so that people say, okay, Dartmouth-Hitchcock, cardiovascular medicine is the gold standard, is the place we would like to learn from, in terms of academics, clinical care, and innovation. So 4 Ps, my goal, people, program, process, and prestige.
That's great. Thank you for sharing that. Now, we are in a COVID era, and people have a lot of questions about the impact of COVID on cardiac function. Early on in the pandemic, there were a lot of stories that came out that identified that sometimes cardiac issues were some of the kind of initial signals that somebody was coming down with COVID. And I actually believe that one of our early patients actually was on the cath lab table, and we figured out that they were COVID positive. And but that was really in the first days. Has that actually continued to be a kind of a dominant early indicator that somebody may actually have COVID, but just have different symptoms than one would expect?
So having experienced firsthand in New York City how COVID had attacked us, I think, COVID and the heart is really an important topic for academic clinicians, and also, for our community, knowing the data is number one thing. So the direct impact of COVID to the heart has been recently published as a registry data. So 8% of the hospitalized patient plus non-hospitalized patient will have irregular heart rhythm. Okay, atrial fibrillation, atrial arrhythmia, we call it. So irregular heart rhythm happens frequently. 8% of this cohort of patients suffered from heart attack directly from COVID. So this is not insignificant. And my experience in New York is the same thing. Our very first patient came from the airport, JFK, and with what appears to be a heart attack, but as it turned out, is myocarditis, inflammation of the heart muscles caused by COVID. So these are direct impact of COVID to the heart, especially in the hospitalized patients and patients who are intubated on a ventilator. These cardiac complications are much higher. About 30 to 50% of these patients will have some manifestations of cardiac damage. But I think what's more concerning to me is the indirect impact of COVID to the heart, to our heart health. Why is that? So if you look at our, acute heart attack hospitalization numbers during the COVID pandemic, early in the spring of 2020, there is 40% reduction in heart attack hospitalizations in Spain, in the US, in UK, there are 50% reduction. Where are these heart attacks go? And they found out there is a 50% increase in out-of-hospital heart attacks. Okay, these patients are intentionally avoiding care or delaying care. The data from New York is such that from mid-March to early May, it is estimated there were 6,000 deaths from patients who did not come to the hospital quick enough and died at home, or they come to the hospital too late. Their heart ruptured or their heart valve teared. So all these things, indirect impact is extremely concerning, but that tells us the story, okay, how to take care of ourselves. When you have chest pain, when you have new symptoms of worsening shortness of breath, don't stay at home. Go to the hospital. Our hospital is safe. Your chance of dying from heart attack is much, much higher than having an infection from COVID.
Yeah, that's really great advice. And I think we are seeing that across many disease states, that people delayed coming to the hospital. And so when we actually see them, they're far sicker and much more difficult to care for. Now, we do want to remind our viewers that if you have questions, put them in the Facebook Live news feed so we can actually ask Dr. Taub. And I've got a few here right now, Cynthia. The first one is about AFib. The viewer says, I have AFib and I'm on medication to lower my blood pressure. Can I still undergo surgery? And does AFib increase somebody's risk for a heart attack or stroke?
Very good question. AFib, meaning atrial fibrillation, irregular heart rhythm, is quite prevalent in our population, especially as you age. The prevalence is increasing. It's unavoidable if you're going for surgery and you're having atrial fibrillation. Taking medications to control heart rate and to prevent stroke, you have to take blood thinner. It does put you at a higher risk if you're going for surgery, but this is why you have cardiologists to optimize your therapy before surgery and monitor you carefully during surgery. The risk is not negligible. That's why you need to seek for care to ensure that your surgery is going to be safe.
When we're on the topic of surgery, if you have AFib, is it normal for somebody to have an echo before surgery?
I think it is important, very important, to have an echocardiogram if a patient have AFib, especially if they have symptoms. We want to know what's causing the AFib. Is this decreased heart function? Is this valvular heart disease? And our strategy in managing atrial fibrillation before surgery would be different. So it has to be tailored. Yeah.
I know there are a lot of stories of people having echoes for atrial fibrillation, and people don't realize that sometimes when the atrium is fibrillating, that's actually set up to developing a clot. And have you ever actually seen a clot in an atrium when you've done an echo?
Yes, absolutely. It's rare to have a clot in the atrium, but it happens. The risk of stroke is much, much higher in these kind of patients.
Which is why people need to have appropriate control of their heart rate as well as be on some type of blood thinner, especially if they're young. So it's important for everybody to know the warning signs of a heart attack. This is from a viewer. Can you share what men and women should be aware of and why it's so important to seek care in a timely manner? So this may be an opportunity to talk about women's cardiac assessment because it's a little bit different than men, isn't it?
Yes, absolutely. There are plenty of anecdotes, and we do have research data that's a multi-center clinical trial called Virgo trial, looking at how men and women behave, when they experience heart attack. Certainly, women's symptoms are less typical, meaning crushing chest pain, elephant sitting on my chest. On the contrary, women tend to experience more stomach upset, maybe more palpitations, racing heartbeat, fatigue, jaw pain, teeth pain, neck pain, and so on and so forth. They, they behave differently. Therefore, there's on average 1 hour delay for women to present to the hospital when they are suffering from a heart attack as compared to men. And, as we said, example of COVID, when COVID hit, people delayed their care. So their outcome is dire. So for young women, younger than 55 years age, if they suffer from heart attack compared to the same age group man, their death rate from that heart attack is twice as much. So this is not insignificant.
Yeah.
Women need to understand if they have new symptoms, they need to seek for help. They need to get evaluation.
Yep. Hey, have we seen any evidence of cardiac dysfunction in the long haulers? And those are people who have had COVID but have persistent symptoms, sometimes months after they've recovered from COVID.
Absolutely. COVID never surprises me now. Any symptoms, skin symptoms, COVID toe, you've seen a lot of these examples. And the long haulers occur in about 10% of the COVID survivors. And they experience tremendous mental and physical challenge, just like cancer survivors. They have to really deal with this in the long run. We need to provide integrated and holistic care in terms of cardiac involvement. This is a research in progress. I think there's some cardiac mechanics study that's looking at those long haulers, and there's some subtle evidence of myocardial dysfunction, that might explain why they don't feel well.
Mm-hmm.
And at DH, we are organizing a long haulers clinic where it's interdisciplinary. Many people are involved. I was invited to join. I'm excited to follow these patients who require long-term follow-up from the cardiac perspective. We have experts who are taking care of the kidneys, taking care of the joints, taking care of skin, all comers. We'll continue to learn from this disease and hopefully to help our patients better in the long run.
So yes, I know that a group of our specialists were getting together to do kind of a long hauler clinic, and it'll be the first one in the state, which I think is really important to follow the consequences of COVID, because it doesn't just affect people over the age of 65. We've got some younger people that have had significant symptoms long after they've recovered from the disease. So we've got another couple questions from our audience. The next one is about AV block, or atrioventricular block, or what many people would refer to as a heart block, a block of the conduction system. Are echocardiograms done if somebody has an AV block?
Great question. Yes, conduction abnormality could be associated with cardiac disease. I can just pull it out of my hat. For example, cardiac sarcoidosis, or it's just aging related. So in order to figure out what is the underlying reason for your heart block, you need to have an echocardiogram. That's a start. But following that, you might need other diagnostic imaging modality or functional tests to figure out, to direct you to the right path. I wish I had my expert colleagues here to explain to you more. But the first screening test, imaging screening test, should be echocardiogram.
Describe to our audience, because many have never had an echo before, the procedure to have an echo, because it's probably a little mysterious to people, but they put on a hospital gown, and then you actually put some transducer jelly on their chest, and I'll let you take it from there.
And then you have expert sonographers here at DH will take meticulous interrogation of your heart muscles, heart valves. They can display that on the screen where they can see moving images. And usually, it's painless, but some people might have sore sternum. They might feel pain, but it should be short-lived. And after your procedure of echocardiogram, you can wipe off the gel, and it's water soluble, and you're on your way.
And they actually can watch the echo as it's being done?
Absolutely.
Yeah,
if they choose to. Yeah.
That's real patient participation. How about swelling of your feet and your arms. If you have heart issues, could that be the cause of arm and leg swelling?
Well, if patients have congestive heart failure, they would, some of them can experience swelling, water retention in their feet, legs, and, some vascular issues, where the cardiovascular center, some vascular issues might give you similar kind of swelling. So you need additional testing to figure out, is this from the heart or from the vascular problems or from other things such as high blood pressure? Simple things. High blood pressure, if you have too much salt, you might have swelling.
So not all not all leg swelling is associated with congestive heart failure. It can be many other reasons, but if you have persistent leg swelling and you have symptoms, your primary care provider may refer them to you to get an echo.
Absolutely.
And then the final question is, what lifestyle changes can I make to improve my heart health? People in New Hampshire are actually reasonably healthy. I think we're in the top 10 of the most healthy states in the country. If you look around, there are a lot of people that participate in outdoor sports and are quite healthy. But what are some other lifestyle changes that people should really consider?
Well, number one thing I can tell you is there is no overnight sensation. It's a lifelong kind of commitment to make sure that you do the right thing. It's like what your mother always says, eat your fruit and vegetables, get exercise. There's no trick related to these advices, but I think the challenge is to set up a system to ensure you stick to it. I'll give you an example. I had in the Bronx, I had a 30-year-old lady who had a heart attack. Of course, she was heavy, smoker, and I had a poor diet. I told her, okay, eat healthy, exercise, and come back to see me in a couple of weeks. She showed up with heavier weight, still smoking, and I told her, eat healthy and exercise. She says, doctor, I won't accept your advice of eat healthy and exercise. I learned a lot from the conversation. It's easy to say this is the advice, but how to implement it, how to create a system to make sure it's a sustainable way to stick to healthy lifestyle. So, I don't have extra tips and tricks, but I think to create an environment, that's the key, to have a long-lasting, lifelong commitment and engagement to healthy living. And I believe in 2 days, my colleague, Dr. Mark Krieger, is going to talk in depth about the healthy living recommendations from American Heart Association. And I hope our viewers will be able to participate and listen to his advice on specific issues to improve heart health.
Yeah, well, that's great advice. Good heads up that Dr. Krieger is going to give that presentation. I don't know if you've had a chance to visit our cafeteria yet, but they've done a pretty good job of removing foods that actually may lead to kind of poor heart health, removing deep fried fat foods, and also removing sugary drinks from the cafeteria. Although there are patients that bemoan the fact that they can't get a real Coke or a real Pepsi, but that was a commitment that the organization made years ago. Well, I want to thank you, Dr. Cynthia Taub, for talking with us. I am sure that we'll have many more questions afterwards from our Facebook viewers, and we will put the answers in the Facebook news feed for all of you. Thank you again for joining us. And Cynthia, we're so thrilled that you're here in the Upper Valley and your life has gone full circle and you've returned here to where you began your career in the U.S. So wonderful speaking with you today.